So what is the role of a pediatric urologist in the multidisciplinary urinary incontinence streams for children? It depends from place to place. It's guided by the funding models of the public health care. In Australia, I think Sydney has a slightly different model to Melbourne, which is slightly different to Brisbane. Perth is different. North America and Europe is what I can speak about in an unbiased fashion. Urologist still tends to be the team leader of this multidisciplinary team. Nevertheless, it doesn't matter who the leader is, somebody has to be the leader, but it's really important to have a multidisciplinary team. And the urologist coordinates the invasive investigations, doesn't matter what his role otherwise in the team is, and then looks at offering therapeutic interventions for the small number of children who merit. So I'm going to look at the investigative role as well as the therapeutic role of a pediatric urologist in this talk, once again reinforcing that majority of the treatment happens in the community level or at the multidisciplinary level, which involves urotherapy, and only a small proportion come to this level of testing. The investigative role is to assist with the investigation of atypical incontinence or incontinence with atypical imaging findings. This is quite self-explanatory. Sometimes a urologist is expected to suggest an approach of invasive investigations in refractory functional incontinence. So this is what I was trying to establish, that there's a stepladder pattern and only a few children come to this point. On the therapeutic side, this part of the urologist's role seems to be expanding a little bit. We not only offer the surgical correction for the urological anomalies, which I mentioned before, and I'll talk to you in a single slide about those, but we are increasingly being asked to offer surgical options for refractory functional incontinence, refractory neurogenic incontinence, and also with children who have difficulties with CIC. The aim of pediatric urological involvement is to complete the diagnosis. Often, ultrasound is not an adequate test to obtain all the information that you would need on a given child with urinary incontinence. And this is because functional and structural problems can coexist, and invasive testing is required. The second role is to risk stratify the kids from a point of view of likelihood of recurrent urinary tract infections, or more importantly, renal damage. And this applies particularly to the neurogenic bladders. And the last aim is to actually fix something that's not otherwise fixable using the rest of the multidisciplinary resources. We saw in the first talk that these are the structural causes for urinary incontinence, and for obvious reasons, they need more investigations by a urologist. But, as I said just then, a large number of tests that the urologists are now doing are not on these structural anomalies. They're actually on the refractory functional incontinence or refractory neurogenic incontinence children. Once again, these are not majority of the children that you see, but they seem to be an increasing proportion that's coming through to us. Invasive investigations should only be considered after weighing their risks and benefits. But what are they? Urodynamics has been mentioned twice. Petrina and Antoinette both alluded to it, and I'll discuss a little bit more about it. Examination under anesthetic with cystogenitoscopy is often considered by urologists for children who are difficult to diagnose. Nuclear medicine studies and CT and MRIs. Somebody was just asking me just then in the break about should somebody in the community organize a CT scan for a child with incontinence. There are no strong guidelines about it, but my personal feeling would be to go through a urologist. So urodynamics, I would encourage each one of you even working in the community to go and attend one of these. Because unless you see it, you do not understand how invasive it is. Because the definition of invasiveness varies from person to person, and it's probably the threshold is highest in New South Wales about anywhere in the world. Secondly, you also do not understand what the benefits of doing it are unless you attend one of these. It sounds a little bit like the pictures from the Mars shown by the space module that's going around, and you're sitting in your own physician's clinic trying to make sense of it. So I encourage you to try and attend at least one of these if you can. It's a very specialized activity, as was mentioned before. And it's a very challenging activity because of the age group that we're dealing with. Imagine imagine putting two catheters in a 2-year-old and asking him to lie still for 15 minutes. It's not easy. Needs sedation, needs a whole lot of things. The other issue is, are we putting catheters in urethras that have sensations or not? That impacts. Nevertheless, it's the most objective test of bladder function that we have available today. This is something that should not be lost on us. It can reveal causes of incontinence which are not otherwise picked up. It can actually tell you what the storage pressures of the bladder are, what the nature of the overactivity of the bladder is, what the leak pressures are for the bladder. And more importantly, in most of the centers, all 3 children's hospitals in New South Wales offer this test. And in most of these centers, it's done concurrently with a with a fluoroscopy machine. So you can actually see the anatomy as it happens. The real-time ultrasound is showing you a lot of the anatomy, increasingly improved resolution, but it does not show you the upper tracts. So when the bladder fills up, what proportion of the urine is flowing up into the kidneys and putting the kidneys at risk is something that you can only find out if you do a video urodynamic study. The other invasive test that the urologists can sometimes employ for incontinent children is an examination under anesthetic and cystogenitoscopy. This is useful in conditions like ectopic ureters, when despite a lot of imaging, you will still be without a diagnosis. In the more common group of functional incontinence, cystogenitoscopy can have an exclusionary role in excluding plumbing problems, but also can give you surrogate information such as cystitis cystica, which is a concomitant finding. In cases where CIC is becoming progressively more difficult, a cystogenitoscopy can give you the causes for that. Moving on to treatment for non-structural refractory incontinence. There are things which we do often, such as botulinum toxin. I will try and not use the word Botox, but botulinum toxin injections. There's some things which Antoinette mentioned to you before, such as Mitrofanoff procedures, which we do very occasionally, and augmentation and artificial urinary sphincters are almost not done anymore. Now this next couple of slides is something I want you to take away with from this talk. Botulinum toxin injections are a revolution. We perhaps are the least advanced in the whole world. The Americans, the Europeans, and the rest of the world is miles ahead of us in experiencing and developing newer ways of using Botox in children who have been distressed with incontinence. And part of the reason is the licensing that we have. We still don't have Botox licensed for children in this country, for urinary incontinence, I mean. It is, Medicare does not pay for it. Botox is how a plumber can actually fix an electrical problem. It works on the sensory and the motor blockade of the bladder. It is enormously effective. It's injected endoscopically, and there's an ever-expanding list of indications of use of Botox with great success. I worked in Western Australia for a year, and they have excellent outcomes of using Botox in indications which New South Wales has not even thought about. As I said before, there's an ever-expanding efficacy profile. There's an ongoing response despite multiple injections, and requires much less compliance from patients and families than some of the other techniques in refractory incontinence. But it does have a 5% rate of bladder retention, and hence the need for intermittent catheterization, and a UTI rate because it's an invasive investigation after all. I will share with you the experience from Western Australia. These are the indications that they are using. Neurogenic and idiopathic urinary incontinence. And these are the numbers over 2 years. Acute and chronic urinary retention with dysfunctional voiding, chronic dysfunctional voiding, and detrusor sphincter dyssynergia, which is the neurogenic bladders. New onset hydronephrosis, both in neurogenic and non-neurogenic, and autonomic dysreflexia. They have fine-tuned the art of where the Botox should be used and in what doses to minimize retention and other bladder side effects. No patient in Australia has yet had a systemic side effect from Botox injection into the bladder. There's a lot of information out there that's scary, but just doesn't happen. The other good thing that's come out of the West Australian experience is the efficacy of Botox despite repeated injections. So no matter how many times, the effect usually lasts about 9 to 12 months. And no matter how many times you use it, it remains equally effective. So I really want you to walk away with the message that if you have a child who is very difficult to get dry and is poorly compliant, and you need to break the cycle, the vicious cycle of wetting and dissatisfaction in the family, please, please, please consider Botox. It isn't as invasive as New South Wales believes it to be. As Antoinette mentioned before, Mitrofenov is a very useful but highly complicated operation for some of the neurogenic bladder patients who are not able to catheterize themselves. These are a highly select group, but their quality of life improves dramatically if you can align the appendix and make it accessible on the anterior abdominal wall. Typically, we do it for unsafe bladders in children, in female children with spina bifida. As I mentioned before, artificial urinary sphincter and bladder augmentation surgery is very, very uncommon. And one of the major reasons for that is the success of Botox. I will not go through this again. Antoinette did a great job telling you what the risks and advantages of bladder augmentation surgery are. And this one slide just to summarize the structural problems that I alluded to in my earlier talk and the surgical solutions for those. Through this brief talk, I just want you to take away the message that the urologists do consider invasive investigations, and they are of enormous benefit to a selected group of children with incontinence. Options for urological treatments for incontinence are increasing and becoming relatively less invasive. Botulinum toxin injections are being increasingly offered with a lot of success for a variety of indications, and complicated reconstructive surgery should only be considered to improve the quality of life of selected patients. Thank you.